Hello friends, today we are going to discuss about diabetic ketoacidosis. So diabetic ketoacidosis is the serious and potentially life-threatening complication of diabetes mellitus. It represents the state of insulin deficiency with concurrent elevation in the counter-regulatory hormone. The annual incidence ranges from the 4.6 to 8 cases per 1000 diabetic patient, and DK carries the mortality rate of 2% to 12%. So DK occurs more commonly in patients who have type 1 diabetes as compared to the patient who have type 2 diabetes. So pathophysiology. So DK is the complex disorder metabolic state characterized by hyperglycemia, ketonemia, and acidosis. So DK usually occurs as a consequence of absolute or relative insulin deficiency that is accompanied by increase in the counter-regulatory hormone. This type of hormonal imbalance enhances hepatic gluconeogenesis and glycogenolysis, resulting in severe hyperglycemia. So, enhanced lipolysis increase the serum free fatty acid that are then metabolized to alternative energy source in the process of ketogenesis. This resulting in the large quantities accumulation of large quantities of ketone bodies and subsequent metabolic acidosis. So ketone include acetone, 3-beta hydroxybutyrate, and acetoacetate. The predominant ketone in the blood is 3-beta hydroxybutyrate. There are several mechanisms responsible for fluid depletion. These include osmotic diuresis due to hyperglycemia, vomiting, commonly associated with the decay, and eventually inability to take fluid due to diminished level of consciousness. Electrolyte shift and the depletion are in part related to the osmotic diuresis. Hyperkalemia, hypokalemia need particular attention. Then precipitating factors are infection, medication non-compliance, inadequate insulin dosing, and new onset diabetes mellitus. Other precipitating factors are acute myocardial infarction, stroke, acute pancreatitis, trauma, pregnancy, surgery, alcohol, and abuse medication like corticosteroid, thiazide, phenytoin, beta blocker, and dopamine. So clinical presentation. Metabolic abnormality associated with the decay usually develop rapidly within 24 hours. However, signs and symptoms of poor diabetic control may precede the decay by several days. So, patient may present with polyuria, polydipsia, weakness, fatigue, and altered sensory. Abdominal pain, nausea, and vomiting are common features in the decay that usually resolves with the correction of acidosis. Persistence of this feature after resolution of the decay may signify the presence of intra-abdominal process. The other on physical examination, signs of hypovolemia are often present, including dry mucous membrane, decreased skin turgor, tachycardia, and hypotension. Additionally, patient may have fluty odor due to their breath as consequences of acetone release. Deep and the labored breathing or small respiration may also be observed under attempt to correct metabolic acidosis with compensatory respiratory alkalosis. However, excess acid cannot be expired. Mental status can range from intact sensorium to diabetic coma. Then about lab investigation, initial lab evaluation, the decay include measurement of serum glucose, electrolyte, blood urea nitrogen, and creatinine, and urine analysis. Testing for ketone in the urine and serum, and assessment of serum osmolality and ABG. Further testing may be done to identify potential infection and myocardial infarction as decay precipitate. These tests may include complete blood count with differential, urine and blood culture, cardiac enzyme, ECG, and imaging studies such as chest radiography. So, hallmark of lab finding in decay are hyperglycemia, ketosis, and acidosis like arterial pH less than 7.3 and bicarb less than 8. So decay can be classified into three categories: mild decay, moderate decay, and severe decay. So mild decay is arterial pH of less than 7.25 to 7.3 and serum bicarbonate of 15 to 18 and an gap of more than 10 and mental status will be alert. Moderate decay, the arterial pH will be 7 to 7.7 to less than 7.25, serum bicarbonate 10 to less than 15, Anand gap of more than 12, and mental status will be alert and drowsy. In severe decay, the arterial pH is less than 7, serum bicarbonate is less than 10, and Anand gap is less than 12, more than 12. The mental status will be stupor and the coma. The presence of high Anand gap metabolic acidosis and decreased level of serum bicarbonate and elevated potassium level are common features in the decay. So normal also low level of potassium typically indicate total body potassium deficiency and require vigilant monitoring and depletion. In comparison with high serum osmolality seen in hyperglycemic state, serum osmolality is variable in the decay. Amylase elevation is seen in 21% to 79% of decay case, often from non-pancreatic source. Lipase can be elevated, but it is marker of pancreatitis. Therefore, clinical judgment and follow-up of patient's clinical status as decay is treated are imperative to differentiate between these two processes. Mild leukocytosis ranging from 10,000 to 15,000 may be due to dehydration, stress, and the demargination of the leukocyte. A higher WBC is often indicative of infection. Now about differential diagnosis. Clinical presentation and lab data often provide the needed information for diagnosing decay. Other causes of ketosis, high NAND-gap metabolic acidosis besides decay should be considered. Although less common, ketosis can occur in hyperosmolar hyperglycemic state. This clinical scenario is distinguished from classical decay by elevated serum osmolality that is more than 320 and marked elevation in the serum glucose that is more than 600. Starvation ketosis, alcoholic ketoacidosis can both produce serum ketone, but unlike decay, serum glucose is not significantly elevated in this condition. In addition, the acidosis are associated with alcohol, rarely resulting serum bicarbonate level lower than 80. The differential diagnosis of high non-gap metabolic acidosis include lactic acidosis, renal failure, and drug intoxication. Measuring serum lactate and salicylate level, obtaining toxic screen, and calculating osmolar gap are also helpful in distinguishing this process from decay. Now about management. The keys to successful management of decay are fluid resuscitation, insulin therapy, correcting metabolic acidosis and electrolyte imbalance, and identifying and treating precipitating factor. Frequent monitoring is required to achieve these goals and avoid the complication. Flow sheet tracking the metabolic process of patient can be helpful. Although elderly patients are most often affected by hyperosmolar hyperglycemic state, they require special attention since death due to decay tend to occur at extreme of age. Treatment of the decay in elderly patient is similar to that of the younger patient. Although fluid resuscitation should be followed more closely in order to prevent volume overload. Now about fluid resuscitation. Patient in decay have total water deficit of approximately 5 to 8 liter and correcting this deficit will result in significant metabolic improvement. So fluid resuscitation with isotonic saline that is 0.9% NaCl at 15 to 20 ml per kg per hour for first hour is recommended for all patients. Therapy should be tailored based upon volume status and serum sodium concentration. In patient with hypovolemic shock, infusion of 0.9 NaCl should be continued and the addition of plasma expander should be considered. When hypovolemia is mild, the fluid should be selected based on serum low serum sodium requires 0.9% NaCl at the rate of 4 to 14 ml per kg per hour. If sodium levels are normal to high, changing to low salt content infusant that is 0.45 NaCl at a rate of 4 to 14 ml per kg per hour is recommended. The aim is to correct total body water deficit in first 24 hours because rehydration will lower the plasma glucose and osmolarity and serum level must be monitored very closely. When blood glucose falls below 250, 5% dextrose should be added to NaCl to continue to prevent iatrogenic hypoglycemia. Dextrose supplementation with the target blood glucose level between 150 to 250 should continue as long as insulin infusion is required to treat acidosis. To avoid complication of rapid fluid shift, the change in osmolality should be no greater than 3 osmol per kg of free water per hour. Sodium changes should not exceed 1 mol per hour. About insulin therapy, regular insulin administered intravenously is optimal choice for treatment of DK. Previous controversy over the use of high dose versus low dose insulin regimen have been resolved. Several studies have shown that low dose insulin effectively correct metabolic acidosis without precipitating rapid decline in plasma osmolarity, glucose, and potassium. A low dose protocol with the bolus of 0.1 unit per kg followed by continuous infusion at a rate of 0.1 unit per kg per hour should be initiated. If plasma glucose does not decrease by 50 to 75 mg per dl in first hour, the rate of insulin infusion should be doubled every hour until goal reduction is achieved. Once the blood glucose is less than 200, the rate of insulin infusion can be decreased. Because ketoacidosis typically take longer to resolve than hyperglycemia, insulin infusion should continue until acidosis resolves. Serum and urine ketone may remain positive after correction of acidosis, as evidenced by closure of anion gap due to conversion of beta hydroxybutyrate to acetoacetate. Criteria for resolution of decay include pH greater than 7.3, serum bicarbonate concentration of 18, and blood glucose levels of less than 200. Once decay has resolved, the transition to subcutaneous insulin can be begun. The American Diabetes Association recommended that basal subcutaneous insulin and insulin infusion be overlapped for 1 to 2 hours to prevent rebound hyperglycemia and recurrent decay. In practice, a longer overlap period may be required and depending on the pharmacokinetic of basal insulin selected. Non-diabetic patients should return to their home insulin regimen, which can be adjusted as needed to control hyperglycemia. Newly diagnosed diabetic patients should receive mixture of long-acting and short-acting subcutaneous insulin. Most patients with type 1 diabetes require total daily dose of insulin zero point 0.5 to 1 unit per kg per day. Half of the dose should be administered as a basal insulin. Once daily glargine and determine or divided equally in two doses of NPH insulin. The remaining half should be administered in three equally divided doses of rapid acting insulin analog before each, that is aspartate, lispro, and glulisin. About electrolyte depletion, patients in the decay have total body potassium deficit of 3 to 5 ml equivalent per liter. However, serum potassium is commonly normal and elevated at prevention. If serum potassium is less than 3.3, insulin administration should be deferred and potassium should be repleted to prevent life-threatening complications of hypokalemia such as cardiac arrhythmia and respiratory muscle weakness. If serum potassium is between 3.3 and 5.3, 20 to 40 milliequivalent of potassium can be added to each liter of intravenous fluid once good urine output is assured. If serum potassium is greater than 5.3 m equivalent per liter, potassium repletion is unnecessary. However, potassium level should still be monitored closely. A target serum potassium is 4 to 5 milliequivalent during treatment of decay. The total body phosphate deficit in the decay averages 1 mol per kg of body weight. Several studies fail to show benefit from phosphate replacement. However, ADA recommended repletion in patients with cardiac dysfunction, respiratory depression, or serum phosphate less than 1 mg. Because acidosis typically resolve with treatment for decay, bicarbonate level will rise without supplementation. Several studies have shown no benefit to bicarbonate administration at pH greater than 7. However, no studies have addressed the bicarbonate therapy in patients with the pH below 6.9. For pH between 6.9 to 7, ADA recommended administration of 50 ml of sodium bicarbonate in 200 ml of sterile water with 10 milliequivalent of potassium chloride infused over 1 hour. For patients with the pH less than 6.9, ADA recommended administering 100 ml of sodium bicarbonate in 400 ml of sterile water with 20 milliequivalent of potassium chloride infused over 2 hours. Venous pH and bicarbonate level should be measured every 2 hours, and treatment can be repeated every 2 hours as needed until pH exceeds 7. Now, highlights of decay management. About fluid recirculation, start 0.9% of NaCl at 15 to 20 ml per kg per hour for first hour. Then, if sodium is normal or high, give 0.45 NaCl at 4 to 14 ml per kg per hour. If sodium level is low, give 0.9 NaCl at 4 to 14 ml per kg per hour. Add dextrose when glucose is less than 250. Goal is to correct the total body water deficit in first 24 hours. Regarding insulin infusion therapy, zero point 0.1 unit per kg bolus followed by continuous infusion of zero point 0.1 unit per kg per hour. Goal is to decrease glucose by 50 to 75 mg per dl per hour. Continue insulin until pH, bicarbonate, and the anion gap normalizes. Then overlap IV insulin with subcutaneous insulin for 1 to 2 hours after resolution of the decay. Insulin electrolyte repletion. Add 20 to 30 milliequivalent of the potassium in each liter of IV fluid if potassium is less than 5.3. Replace phosphate if phosphate is less than 1. Give bicarb if the pH is less than 7. So this is the schematic representation of management of the decay. So evaluation, check blood glucose, serum and urine ketone and confirm hyperglycemia, ketonemia and ketonuria. Then start IV fluid that is 1 liter per hour of 0.9% NaC. So before giving IV fluid, determine hydration status. If severe hypovolemia, administered 0.9% of NaCl of 1 liter per hour. If it is mild dehydration, then evaluate corrected serum sodium. If serum sodium is high, then give serum sodium is normal, then use 0.45 NaCl 250 to 500 ml per hour depending upon the hydration state. If serum sodium is low, then give 0.9% of NaCl 250 to 500 ml per hour depending on the hydration state. When serum glucose reaches 200 mg per dl, change to 5% dextrose with 0.45 NaCl at 150 to 250 ml per hour. If the patient is in cardiogenic shock, then while giving fluid, hemodynamic monitoring and pressures as needed. About insulin, there are two ways of giving insulin, IV route and subcut route. In DKA, start with the IV route that is 0.1 unit per kg as a bolus and then 0.1 unit per kg as a continuous infusion. If serum glucose does not fall by 50 to 70 mg per dl in first hour, then double the IV and subcut insulin dose. When glucose reaches to 200, then reduce the regular insulin infusion to 0.05 to 0.1 unit per kg per hour. IV or rapid acting insulin at 0.1 unit per kg subcut every 2 hours. Keep the serum glucose between 150 to 200 until resolution of the decay. If it is uncomplicated decay, then use the subcut route. Rapid acting insulin that is 0.1 unit per kg, then 0.2 unit per kg uh, 1 hour later. Rapidly acting insulin in the dose of 0.2 unit per kg subcut every 2 hours. Then about the potassium, establish adequate renal function. If potassium is less than 3.3, hold insulin and give to 20 to 30 milliequivalent of the potassium until potassium is more than 3.3. If potassium is more than 5.5 5.3 milliequivalent, do not give potassium and but check the serum potassium every 2 hours. If potassium is more than 3.3 but less than 5.5, give 20 to 30 milliequivalent of potassium in each liter of the IV fluid to keep serum potassium between 4 to 5. Then assess for the bicarb. If pH is less than 6.9, dilute soda bicarb that is 100 milliequivalent in 400 ml of the water with 20 milliequivalent of the KCl. If pH is 6.9 to 7, then also give the bicarb correction. And if the pH is more than 7, do not give any bicarb correction. Repeat bicarb administration every 2 hours until pH becomes pH become above 7. For electrolytes, check electrolyte, blood urea nitrogen, venous pH, creatinine, glucose every 2 to 4 hours until stable. After resolution of the decay, when the patient is able to eat, initiate subcutaneous multi-dose insulin regimen. Continue IV insulin infusion for 1 to 2 hours after subcutaneous insulin has begun to ensure adequate plasma insulin level. In insulin new patients, start at 0.5 to 0.8 unit per kg of body weight per day and adjust the insulin as needed and look for precipitating cause. Now about the complications of treatment diabetes mellitus. Complications are hypoglycemia, hyperglycemia, hypokalemia can occur, hyperchloremic acidosis can occur, thromboembolism, fluid overload, cerebral edema, and hypoxia and acute respiratory distress syndrome. If hypoglycemia, check the glucose every hourly or a low dose insulin infusion protocol. In case of hyperglycemia, overlap insulin infusion and subcutaneous insulin once decay resolved. In case of hypokalemia, check the potassium every 2 to 4 hourly. Supplement potassium if potassium level is less than 5.3. Hyperchloremic acidosis is resolved quickly and frequently clinically insignificant. Thromboembolism, no data support prophylactic anticoagulation. For fluid overload, monitor total body input and output. For cerebral edema, check the serum sodium every 2 to 4 hourly. Check serum osmolality every 2 to 4 hours and replace the fluid gradually. In case of hypoxia, ARDS, add dextrose if the glucose is less than 250. Avoid changing sodium at rate of more than 1 and avoid changing osmolality at rate of more than 3 mmol per hour. Thank you guys.